my name's Pippa Horsefield. I'm an anaesthetic registrar in Sheffield, and I'm going to present a case that myself and my consultant Flo Roberts were involved with just before Christmas. And this was a case of a lady who survived a massive obstetric hemorrhage without receiving any blood products. So I'm going to talk about the clinical management of the case, but there are also some ethical issues with regards to consent that are quite interesting as well. So this lady ticked all the risk factor boxes. She was 46, she was a grand multipara, she was hypertensive, diabetic and obese. She was a Jehovah's Witness and she had an advance directive that declined all blood and blood products. And as if all this wasn't enough, English was not her first language, so communication with her was very difficult. Now, I've had to condense the history due to time pressures, but essentially she had a large antepartum hemorrhage, was diagnosed as having abrupted, and then deteriorated quite significantly. She was in hypovolemic shock, and the decision was made to have an emergency caesarean section. She was seen preoperatively by the anaesthetist and the obstetrician. We knew that she had an advance directive, but as I think most people would do, she was just asked to confirm that if her life was in danger, would she accept blood? Now, in that situation, she had some family members in the room with her who were not religious, and they had a conversation with the patient in a language that we didn't understand, the result of which was that the family said, yes, if she's going to die, she will have blood. Now, understandably, we had reservations about the validity of that consent, but we were unable to explore that further. She was deteriorating rapidly, her abdomen was huge, she needed to go to theatre fairly quickly. So she did. She had a caesarean section and a baby boy was delivered, which was unfortunately not alive. She actually had a cuvulaire uterus, so she bled into the myometrium, and there was a lot of blood. She had about 3.5 litres in her abdomen, possibly up to another litre within the uterus itself. And the decision was made to perform a hysterectomy, which was done quickly, and that was a good decision. Anaesthetically, she had a modified rapid sequence induction, which was uneventful. She had volume replacement of crystalloid via rapid infusers. She had a vasopressin infusion to maintain a blood pressure, and the cell salvage was processing blood on the emergency mode. But she was very, very poorly, as I'm sure you can imagine. So she'd lost up to 4 litres of blood. Excuse me, her haemoglobin was 47 on a gas. She was coagulopathic in DIC. She was acidotic. And we were getting to the point where we were thinking, what do we really think about that consent that we've just had? We decided to give her Novoseven, and I think we'd given her tranexamic acid a bit earlier. And it worked really, really well. She stopped bleeding, and by the end of the operation, she was looking really rather good. She was still passing urine. Her phenylephrine infusion had come down and was almost off. She wasn't oozing at all. And her haemoglobin, with about 1 litre of cell salvage blood, had come up to 81. Now, she had lost a lot of blood. It was 2 o'clock in the morning. We decided to keep her sedated and ventilated on ITU overnight, where she continued to make a remarkable recovery. She was extubated that morning and was ready to go to the ward later that afternoon. Further management included erythropoietin and Ferinject. By day 5, she was at home on oral iron. Now, the consultant obstetrician said that she had never seen anyone with that much blood in their abdomen survive without receiving blood products. And what I'd like to highlight is what we feel made a difference in this case. One was the early decision to perform a hysterectomy. One was having the cell salvage on emergency mode, which can be easy to forget in a pressurised situation. But we feel that giving the Novoseven really helped us prevent making that really difficult decision about whether we would actually give her blood or not. So Novoseven is actually only licensed for use in haemophilias, but there are multiple case reports and anecdotal evidence of where it's been useful in major hemorrhage situations. Now, all these case reports that I was reading are used after blood products have been given. Obviously, in this case, we gave it without any blood products. Now, due to its mechanisms of action, you should really have adequate levels of fibrinogen for it to work well. But this lady's fibrinogen level was really low, and it still worked really well. And we feel that it was giving this that made us not have to make that really difficult decision. Which brings me on to the issues of consent. So the family were saying that she would accept blood and blood products. We didn't know that what they were saying was, well, shall I put it, being economical with the truth. She might have agreed to blood, but it might have been under significant pressure from the family, in which case that's consent under duress and would not be valid. We've also got to take into account her clinical condition. She was very shocked. She might not have had capacity to make that decision. But on the other hand, she might have been fully aware of what was going on, and she might have changed her mind. She might have said, yes, I will accept blood products. Can you tell them that? We just didn't know. Now, incidentally, once she was extubated on ITU, her English was actually a lot better than it had been when she'd been bleeding to death. And she was actually very clear that she would not accept, under any circumstances, blood or blood products. So, yeah. So in summary, this is a lady who survived a significant blood loss without receiving blood products. And we feel in this case, it was the Nova-7 and the chamic acid that made the difference and prevented us from having to make that really difficult decision. So thank you for listening. Does anybody have any questions?
Hello, hi. If you say that language was a barrier, how did you establish that she was okay for cell-salvage blood?
So she had an advanced directive,
Okay.
which I think detailed what she would and wouldn't accept, but it was her own blood. It wasn't extraneous blood that we were...
No, it doesn't make a difference. You still have to confirm whether they'll still have their own blood.
I mean, she would have been thoroughly pre-assessed in clinic, and that discussion would have been had with her.
Yeah, but did you have that at the time that this was discussed?
Another question in front here.
Thanks. I'm very glad I wasn't on duty on that then. So you said it worked, but there's no clotting studies presented. What do you mean by it worked? And in fact, do you know what the clotting studies were?
I do have them. I've brought them up with me. I just didn't have time to put them on. So, do you want to know what?
Well, it's just the phrase "it worked." To know what does that mean?
In that situation, just observationally, she stopped bleeding, she stabilised, the phenylephrine started coming down, she wasn't oozing from a surgical point of view. She was coagulopathic, and from blood results that were taken intraoperatively, they corrected themselves over the next 5 days to back to normal. So her fibrinogen was low, PT and APTT were both significantly raised.
Third row back.
You said you were in a kind of dilemma, isn't it? So if she continued to bleed, and if she was going to die, what would you have done? Like, would you have gone with the last minute kind of change in the consent, or?
I don't think we know. I think at the time, the general consensus of opinion was that it could have been valid consent, but we all had significant reservations. I think if none of us had reservations, we would have given blood and given it sooner. But yeah, I'm very glad that we weren't pushed to that point where we really did have to decide, because I don't know what we would have done.
Okay, one last question. Second one again.
I'm always under the impression that factor 7 has to be authorized by the hematologist. And I've been in this scenario before, not with the Jehovah's Witness, but a massive obstetric hemorrhage. And in my case, the hematologist did not authorize until the fibrinogen levels were normal. So how did you get around that?
I think in the pressurized situation that we were in, we might have omitted to inform the haematologist.
If I was a haematologist on call, I would say to have it. I mean, the reason it is now black triangles and do not use outputs product license is the 10% risk of material resistant misuse. So it's a dangerous drug. But I have seen it, we have used it again, been pushed to another Jehovah's Witnesses in Sheffield, a woman who had a hemicolectomy, and she bled and bled. And effectively, how it works, it drives thrombogeneration, clot formation, in the absence of other clotting factors. It's a bypassing agent. So we use it in people with haemophilia who've got inhibitors, and people whose platelets don't work. It's very good at making clots. And I have no doubt it works better if the patient's not acidotic, if the fibrinogen is okay, and your clotting factors are reasonable, and the patient's not cold, they're much more likely to work. So I think it depends on what setting you're using it. In this patient, we didn't have anything else left with her really, and she was actually bleeding out. The only option we had was snowsy. If you put somebody who's not a Jehovah's Witness patient, if you replace their clotting factors, then there's no real evidence that novocin is any better than replacing the rest of the hemostatic defect. So I think it depends on the circumstance in which you find yourself. But yes, so we would have, we knew where to find it, but we would have given it to the call. But I was on call. It was 22nd of December, wasn't it? I was on call. And you didn't always
Thank you, Philippa.
Hello, I'm Umar. I'm one of the anesthetic registrars in Hull Royal. And this is a project that I did with my wife, Zuna, who is Obs and Gynae registrar. So this is Major Obstetrics Emergency Simulation Training course. The real reason why we did it's the preeclampsia, postpartum hemorrhage, and sepsis is still leading cause of maternal mortality and morbidity. Especially if you look in Pakistan, it's about 80% direct causes, and PPH is the highest over there. We know that simulation helps improve participants' knowledge, confidence, and behavior. There is an emerging evidence that it helps in reduction of morbidity and mortality as well. So we decided to use simulation-based training. This was delivered in Pakistan PIMS Hospital, which is a tertiary referral center, and that was done on 31st of March 2016. And this project was endorsed by RCOG. So objectives were fairly simple, to be honest, to improve multidisciplinary teamwork, facilitate RCOG Global Health Project, which has been going on for a while, and then improve participant knowledge and confidence. I think the overall aim was to improve patient safety in the longer run. So this is sort of a course plan. I'd like to go in a bit of detail in that. The reason we chose simulation as well as lecture was to satisfy different learning styles we all have. So there was a good amount of pre-briefing done for the simulation because it's quite new over there. Every scenario was followed by immediate debriefing and then the lecture to facilitate the knowledge delivery. I specifically emphasized on putting the importance of human factors lecture in there because obviously we can make a lot of inroads in developing countries through delivery of these lectures. Now, I would like to focus on the photograph on the top. This is sort of, I think it's an innovative method which I used over there, and that was to think on the ground. We were expecting only 20 participants, but on the day 138 turned up. So we had to deliver it to everybody, and the aim was not just those participants who were involved in the simulation get the benefit of it. So what I did was we have got this Simon, which is a very simple app. It connects to your iPhone. I put a camera in front of the computer and connected it through the projector. So if you see on the top, you can see the live monitoring being displayed, and this has got an audio as well. So it was the participants were involved in the scenario itself, but everybody could listen to the change of the vitals and the sound itself. So it was involving more of the public rather than just the participant. And I'll give you the results. So first of all, it's the methods. 138 participants, which was very good for us. 20% were students, and more than 1/3 were from the district hospitals, very rural settings as well. We sent invitation to everyone, and everybody accepted it. So it was really nice. And only 25% had previous simulation training, which accounted for BLS as well. So it was very new to them. We used actors. We trained them a day before and asked them to keep the scenarios to themselves if they could. Live monitoring was used. We had hands-free mic, so that again helped us that they can deliver the scenario as they moved along. And then actual team responses. So this was delivered in the lecture theatre, but then we would identify the teams, get the participant out, and then they will call them as they were needed. So the results were very encouraging. So one is not much confidence to very high confidence at 5. And if you see, the pre-course is mostly on 1, 2, or 3 side, and the post-course is on the right side. Again, there was confidence in managing obstetric emergency. One of the aims was satisfied there. Importance of human factor, I think that was, it generated a lot of interesting discussion when I delivered the lecture, as well as during the simulation scenarios. And then awareness of RCUG guidelines. RCUG guidelines are quite prevalent in Pakistan, but it was just to reinforce them because a lot of guidelines there are derived through the RCUG guidelines. And then the feedback was very good. It was realistic. 85% of participants said that. 94% was relevant. 89 would recommend it to others. And I think the most important point is it's all the learning happens in the debriefing. So 98% thought that it was very useful to have that scenario. So just to conclude, I think thinking on the feat itself, there's a lot of drive towards high fidelity mannequin, but you can deliver with using a hybrid technology, which was very simple. We all have got iPhone, iPad, and then projector to project things on. And I think we managed to incorporate a lot of audience rather than the participant themselves. And importantly, I did a subset analysis of those participants who were involved and the participant in the lecture theatre, and then the results were fairly similar. So I think there is because going back to the basics of simulation training, a lot of learning happens in the debriefing. So it's not the actual acting of it, it's the debriefing which is important, so you can generate the same amount of response. There is much more increased awareness about human factors in the development, which is very good from 10 years ago when I was a student over there. So I think that things have moved on quite a bit. But again, simulation-based training can help, and then there were a lot of participants who were willing to contribute. What would I say is it was very difficult to arrange all of this. RCOG endorsed it, but they wouldn't let us use the logo, and so there's a lot of demand for logo, and people want to see those things. So advertisement was a bit of a difficulty, and I think there is a need to do better advertisement through proper endorsement. Faculty motivation is required not only by the organizer, but the organization itself as well. And then appropriate grants should be, because this was all self-funded, so we managed to get all the certificates. The local hospital managed to get for the dinner and everything, but I think if it has to be sustainable, then it has to be properly funded so that people can benefit from it. I think that's really it. I'll open for the questions. Thank you.
Questions from the floor?
Thank you for that presentation.
Thank you.
It looks absolutely brilliant what you did. And the question in my mind is, you had such encouraging results. You have put a lot of effort into this project, and obviously I can see it can be implicated or it can be extended to thousands, if not more, of the medical faculty. How do you take it forward? Or how are you going to move it? Because it's not just for Pakistan, it would be implicated in a lot of other countries as well. So do you want to liaise with any of the national organizations like EAG, Fund, or how do you take it forward?
Yeah, thank you very much for asking this. So the first part of it is we are going back in September, and we are going to deliver in another big city, which is Lahore. So hopefully we might get another bigger audience over there. And secondly, we are in touch with Royal College of Obs and Gynae again. It's not only the sustainability, I think, will come from the faculty development, because it's easy for me to go back and then do it yearly, but we need to develop local faculty. So again, I'm thinking about developing faculty development program over there, so local faculty can run it, and it can be supervised. And the third important thing is getting the CPD points for the faculty itself, so that faculty from here could be encouraged to go over there, because everybody has got very busy lives, so you need to have certain program in place so that it can get the sustainability. So these are the things. And now lastly, I'm thinking about going to a GPI and other organizations as well to improve the continuity of it, because we didn't have any simulator to take with us. I did try for a few places, but there was like, no, it doesn't leave the hospital or doesn't go outside. So I think a lot of need is required for the collaboration. We've got the equipment here, we take it over there, get it back, but you deliver it, the high fidelity mannequin or simulation could be delivered through these means. A bit of collaboration, I think, will go a long way.
Any other questions?
Yeah.
I know you have done lots of simulation-based training in a well-established centre like Hull. Did you have any challenges while doing the simulation course back in Pakistan?
I think it was, there are different, I think there are good and bads with everywhere, because we didn't have any internet over there as well, which I've just found out on the day. So, and then I think the reception itself from the audience, which I thought would be, so my perception was that the audience might not be very receptive to it, but it was very contrary, because people were very forthcoming, they wanted to do it, and there was a real desire to learn from it. I think the other bit is that, because they haven't had any much simulation, so whatever you're telling them, they listen very carefully to you, they acknowledge what you're doing for them. So I think it goes hand in hand, the challenges and the benefits.
Great, thank you very much.
Thank you very much.
Hello, my name's Alison Coon. I am an anaesthetic trainee in Sheffield, and I'm going to present our data from 2012 until last year on our reduction in blood transfusion rates peripartum following introduction of IV Ferinject in our tertiary referral centre. So why did we need it? Well, we all know that peripartum iron deficiency anemia is common, and the oral supplements are hard to take. There's poor tolerance and compliance, and there's also patients that can't take them for some reasons. And blood transfusions carry well-known and documented risks. And there's evidence out there that shows that intravenous Ferinject is better tolerated than oral iron and has a shorter effective treatment time. So our aims were to reduce antenatal severe anemia, and when we're saying that, we're saying less than 100. And to reduce postpartum blood transfusion rates. So in 2012, we introduced a standardised protocol, which I'll show you in a second, offering it to anybody antenatally who had a haemoglobin of less than 100, who was non-compliant, intolerant or contraindicated to oral iron, such as those with some inflammatory bowel conditions that can't take the oral iron. Postpartum, anyone who had haemoglobin between 70 and 90 who would ordinarily have been offered a blood transfusion, and those who basically would refuse blood transfusion for, Jehovah's Witnesses, religious or other reason why they wouldn't want a blood transfusion. And then in 2014, we then went on to audit prospectively and retrospectively how that had impacted our blood transfusion rates and how it had impacted the actual patients and their actual haemoglobin levels once they'd gone home. So this was our standardised prescription chart. Was this point? Yeah. So it was standardised for everybody, and anybody who weighed over 35 kilos got the same dose. So 35 kilos, the majority of our obstetric ladies are well over 35 kilos. It was done as a prescription chart, so the booking weight was popped on here. Allergies were documented on this same chart. The indication was ticked. One of our 3 indications was ticked. It was a standard dose of a gram, unless you were less than 35 kilos. There was a checklist on there for the midwives to check that they'd gone over, the risks and benefits had been explained to the patients, for example, that they couldn't take oral iron for some reason or preferred not to have a blood transfusion if they were postpartum. There was the actual prescription, and then there was also a small box on the bottom to make it really easy for the midwives, if there was an adverse reaction, for them to administer the Piriton. Our results, we did very well. Over the first 3 years, we got a 23% reduction in blood transfusion rate, and then that has been sustained over the next 2 years. And this has all been despite we still deliver in our unit more than 7,000 babies per year. Over this time, one patient has experienced mild itching, which was successfully treated with Piriton. And there's been no other major adverse reactions to any of the Ferinject given to our patients. When we looked at those that had received the Ferinject, and we collected it prospectively, the data, for 25 women who were of the obvious maternal age, 18 to 41, they had postnatal haemoglobins between 70 and 90. Pre-delivery, they all had, most of them had normal haemoglobins, but the range was between 86 and 131. And post-delivery, they went down to a mean of 77, and their haemoglobin had dropped by 30. The majority of these ladies, 68% of them underwent a cesarean, 20% of them had a vaginal delivery with instrumental, and 12% of them had without instrumental deliveries. 88% of them received the Ferinject only, 8% of them had packed red cells only, and one patient had both. And when we looked at their haemoglobin rates after transfusion of the iron, it had gone up by 45 over an average of 25 days. This differs from the literature all says that Ferinject gets your haemoglobin up over kind of 6 weeks, but we checked at 25 days average and we were already up to 45 grams increase, and that's just over kind of a 4-week period. So in our discussion, we have found that the Ferinject appears to be safe, well tolerated, effective at increasing the haemoglobin. In 2016, around 385 patients in our unit got it. That would be 300 postpartum and 55 antenatally. Its implementation is likely to have contributed to our decrease in blood transfusion rates. However, there will be other things such as we've got further guidelines of, to reduce the transfusion rates and further targets to reduce the amount of blood that we're giving to patients. But we would hope that that drop appeared to coincide with the Ferinject, and these figures were just for our maternity hospital. They weren't for the whole hospital STH as a whole trust. We use way more blood than that, I'm sure. But we've successfully implemented the Ferinject as part of our active patient blood management, and we feel that because we used a standardised protocol for everybody, it was easy for the midwives. The transfusion itself took 15 minutes and they needed to be observed for 30 minutes afterwards. So the ladies needed 45 minutes of observation as opposed to blood transfusion, the average unit for 4 hours of midwife time. Any questions?
Ian at the front. Mark, you got
Can
back?
everybody hear me? Can you hear me all right? Thanks, Alison. Very interesting talk. There's been a general decline in transfusion rates across the UK.
Yeah.
Well, how much of a role did that general decline play in the figures that you presented, do you think? Did you look at that?
I didn't look at the general decline over the whole hospital. I mean, it obviously has had it, but we've had a steady, from 2013, we've had a steady plateau since the initial first 2 years. And if you look at how much we were using in the first couple of years, we were using very little antenatally and 100 postpartum. We've gone up to kind of 230 postpartum, 300 postpartum. So we've got a steady increase in them 3 years where we had the plateau, and we had very little in the big, big drop.
Can I ask, it's interesting, you gave a lot of the Ferinject postpartum and only about a seventh of it or an eighth of it antepartum. Do you know if you're capturing all the relevant women antepartum to prevent them having anemia at the time of delivery? Do you think there's further room for improvement there?
Definitely. After doing many elective sections in Jessops, there was many ladies coming with a haemoglobin very much bordering on the 100 mark. So we must be missing a significant proportion of them. And that's probably because we, check their bloods at 28 weeks, and then we check them again the day before section, which is the day before section is far too late to give any form of iron therapy to the lady.
Do you have a strategy for improving it?
Not at the present.
So a question here at the front.
So 2 questions. One is, there are a lot of national guidance coming just now to correct the preoperative anemia. Do you think it can be, the project that you did, it can be implicated to other surgical specialty? And the second question I have got is, why did you choose IV, or what made you do this project where normally all pregnant women get iron and all the things? Were you seeing a major failure of your oral iron therapy which led you to this project?
A major failure of compliance more than a major failure of the oral iron itself. So the major side effects, pregnant ladies already get constipated, and then we start giving them oral iron, and then they run into more problems, they just don't want to take it. So it was more about patient compliance than actual failure of oral iron.
Question there.
Thank you very much for the presentation. I just wanted to ask, what was the cost per patient in this case?
Yeah. So if you were to compare it to a blood transfusion, so for the cost of the pharyngectomy it would be £140, and then you've got your 45 minutes of midwife time factored into that, and then you can go home after you've had your iron. You've only got to stay for your 30 minutes observation. If you were to have a unit of blood, you'd be looking at £121, plus 4 hours of midwife time, plus the administrative cost of cross-matching. So we're looking at adding maybe an extra £100 onto that cost for the taking your bloods and the midwife looking after you. But then if your haemoglobin's 70, you're probably going to have 2 units of blood, which is another £124. So if you have 1 unit of blood, you're probably looking at an equitable cost, but then you've got the risk to the patient. And if you're having 2 units of blood, you're looking at a cost saving.
Okay, thank you very much.